Our next presentation is going to be a panel discussion.
So we're each going to do
I
a few
know
minutes
people are
and
still
then
coming in the room, but
back
for
to
you
some
on Zoom,
questions.
let me do the introductions and let the panel take it from there. They are experts in the underserved community here in Rhode Island. And so our first panel discussant is Dr. Don Dizon. The doctor presented here 2 years ago. And he's an expert dealing with the LGBTQ community plus. And I still remember his talk, and I especially remember the humble beginning that he said that he was working with a trans male and his partner, and chose the wrong person for the ovarian cancer. But he humbly admitted that and went on, and it's that kind of humility and that flexibility that allows him to do the work that he does. So we thank you, Dr. Dizon, for being here. The second panelist is Dr. Abdul Sayed Calvino. I worked with Dr. Calvino for several years at Roger Williams Medical Center. He is a surgical oncologist and assistant professor of surgery. Should have mentioned that Dr. Dizon is a full professor of medicine and professor of surgery for Brown University and the Lifespan Cancer Institute.
It's a new phone that you can like.
But Dr. Calvino runs the Surgical Oncology Fellowship for complex general surgeries. And it was recently awarded by the American Cancer Society for his outreach to the Latinx community in improving outcomes for Spanish-speaking patients who needed screening and then treatment sometimes for colon cancer. And our final panelist is Kate McCarthy. I've known Kate a little over 30 years. She kind of follows in her mother's footsteps. Her mother was the outreach coordinator at Roger Williams Medical Center for oncology. Kate has been a tireless advocate for individuals with disabilities. So we've got several of the communities that are underserved, and Kate's going to facilitate this panel.
Well, I guess I will start. Again, the idea of this panel is to have an open discussion. We're going to focus on how COVID has affected screening for different type of cancers, specifically here in Rhode Island. Thank you, Jim, for the introduction. I'm Dr. Sayed Calvino. I'm a surgical oncologist and run the patient navigation and community outreach programs at Roger Williams Medical Center. You know, when I was thinking about how to start this discussion, I thought we have to look into data we have, and we have to look into some data that we still don't have. So the first thing we have to look at when we want to analyze how COVID impacted screening, we have to recognize that there was a period of time where with the COVID pandemic, end of 2019, 2020, where there was no screening being done. Almost for a year and a half, the screening was not a priority. The priority was taking care of patients and trying to get through the pandemic. So there was no screening. There was a recent study that calculated approximately 9.4 million screening studies were not done during that time. We have to first acknowledge that and know that there is going to be an impact on morbidity and mortality from cancer patients. And how that correlates, well, we are expecting, we don't know yet, it's going to take a year or two for us to be able to know that, but we're expecting, and all the people that didn't have the screening when they should have might present with more advanced cancer, and more advanced cancer means higher mortality. So I think the first step is to acknowledge that. we are behind in our screening. So now the next step in my mind is, well, what can we do to not only go back to the pre-COVID rates, but to catch up with all the screening that wasn't done? And that's where I think having a discussion is very important. What strategies can we use to make sure we catch up on all those groups? And if there is something we learned with the pandemic, is that the groups that are going to be more affected are the underserved populations. There are many of them. I work specifically with the Hispanic population in Rhode Island. As you know, 40%, 13.9% of our population is Hispanic. Half of them are in Providence, and the Providence County. So we need to find strategies to get that people back into screening for different type of cancers: breast cancer, colorectal cancer, and lung cancer. And there are some strategies that we know work. For example, patient navigation, being able to communicate with the patient in their same language, someone who understands and is sensitive to the culture, that can explain why the screening is needed and how they can prevent, in some cases, cancer. Patients need to understand that and then try to help the patient access and navigate the system so they can get the test done. I think that's one strategy that we know works. We know patient navigation and culturally tailored patient navigation works well. But the question with that is the funding. And that's where institutions have to try to figure out ways to support different programs. But there are some other ways that we can increase the rates. And one of them is doing what we're doing right now, which is create awareness and collaboration. So if we know that there is a problem and we know we need to catch up on the screening that wasn't done, then we can collaborate between different institutions and we can work together creating awareness. And you create awareness doing this, having a discussion about it, an open discussion about what things we can do. So in my mind, the next step is what strategies can we implement with the resources we have? How can we collaborate and how can we get our underserved populations back to screening? What's the actual impact that we're going to see in mortality? For example, colorectal cancer, breast cancer. It's very difficult to tell. We don't have data right now to know exactly what's going to be the impact, but we know there was a lot of people who didn't get screened, and we know they might present with more advanced disease. Not only that, but with the pandemic, some patients actually, in that time, they didn't want to go to the hospital, they didn't want to go to the ER or to the primary care physician, they couldn't. But a lot of patients now don't feel that comfortable. Even now that we understand COVID better, they don't feel that comfortable going back. So that's what we have to work on, making sure those patients feel comfortable going back and taking back their screening test and educating them. So I hope we can have a very good discussion about what strategies work best and how in Rhode Island we're going to address this problem. Thank you.
So when I talked here 2 years ago, one of the things that was important when it came to understanding the LGBTQ experience in cancer care was to understand that we have no idea because demographics are not being collected routinely and certainly not being done at a national level. And that creates a blind spot for us. There has been data that suggests there are differences among the LGBTQ population when it comes to cancer. What's curious about that is even among the data sets that exist, it's likely they remain invisible. But if you try your hardest using scientific method to find folks who are, say, transsexual or transgender, I should say, what you'll find is there are differences in the types of cancers they appear to have. And it's not the cancers you would think that appear more common in a population taking gender-affirming hormone therapy. There are not more cases of prostate, breast, endometrial. There are more cases of lung and kidney. And there are differences in the access to treatment that I've reported, whereas, say, for kidney cancer, they're more likely not to get treated for it. But again, this is population-based, very poor data because we haven't asked that question. Since that time, the National Academies of Medicine, Engineering, and Science have come out with a report, and it challenges the NIH to routinely collect sexual orientation and gender identity data. In fact, it's implementing that, I think, is well underway at the national or federal level. And that report is an important one for all of us to know, because it also suggests the questions that should be used. Now, I think as far as this panel goes and the cancer experience for COVID-19, we have no idea. Because unless you have that data collected, you have no way to tell, did COVID impact stage migration? Are they presenting with more advanced disease? Did it impact the way treatment worked? Were they more at risk of dying due to incompletion of therapy, due to lack of follow-up, as was suggested? We don't know because we have no idea of baseline. Now, Kelly Smith did provide me some data of what we have collected in an intentional demographic way of everyone who got COVID-19 in the state of Rhode Island in 2021. But even in that data collection, there was over 30% who did not give their sexual orientation or gender identity. Now, you could assume one way or the other, having asked these questions to several patients, sometimes I do get the answer, that is none of your business. So over 30% chose not to disclose, probably because it's none of our business. And that's one of the things I think that education is so important about. If we ask sexual orientation, if we ask gender identity data, two things people need to be comfortable with: the why are you asking me this? And then the what are you going to do with this information? Because it is exceptionally private. And I think those are the two things that are standing in the way of wider implementation of sexual orientation and gender identity data today across cancer centers. It's one thing for folks in leadership to say, we're going to train all of our docs in cultural competence, and everyone is going to have to ensure to remain in good standing in this hospital that you have taken the course on cultural competence when dealing with LGBTQ people. You can teach the docs about mutual respect, but the experience, and this was made clear to me in a panel I was on, the experience of cancer care doesn't begin in the examination room. It begins who greets them at the hospital. It begins at the valet park. And it begins with your medical assistant. And it continues with your medical assistant. And especially in a multidisciplinary cancer care model, it begins with my staff, extends to my surgeon staff, and extends to my radiation oncology staff. At any one point, the risk is that sexual and gender minoritized people will experience discrimination. So it's very much an issue of implementation. And I think for everyone here, the way we go about addressing implementation is to treat everyone in your system as an important voice that we need to teach, we need to learn from, and then we need to get them on board to make this happen.
Great, thank you. So next we're going to talk a little bit about the experiences of people with disabilities who have cancer during COVID, and then we're going to open it up for discussion and dialogue and questions. And so to follow up, we've already heard a little bit about the lack of data. We also found a lack of data for people with disabilities, especially those who identify also as having cancer. Keeping in mind that cancer is covered under the Americans with Disabilities Act. So it's a natural fit when we're looking at our data. What's been interesting with COVID-19 is when we look at this population, there's really two focuses that we can take for people with disabilities. The first one is what's called the medical model, which we would assume would be used in COVID-19, which it was. And what the medical model does is the medical model says that all the interactions that the individual, that the patient has is based on their physical or medical diagnosis. So, for example, if an individual, has cancer, has a disability, that became a very prominent part of the decision-making process. And what we have found in the information that's been shared is the impact that this has had on triage, also on the rationing of equipment and medical supplies and vaccines. And so what we found is the reporting and multiple concerns being raised and civil rights issues coming up that said, just because an individual has a disability, has their own ventilator equipment, has certain components that they need with them, does not mean that they don't have the same equitable right to the same care. We saw that for patients who are deaf or hard of hearing, also those that have cancer who are deaf and hard of hearing, not being able to have the strategies to communicate as well due to the masks. We saw a tremendous population of people who had developmental and intellectual disabilities, and also those who were more severe in where they were on their treatment, having a greater impact in terms of COVID, in terms of the triage. So I know COVID-19 hit all of us in a different way, but the stories that came out, especially for this population of just being left there, Connecticut was a state that fought very hard to go against the concern that they had where only one person or no one could be in the hospital with the patient. We had adults, we had children, we had individuals with disabilities who were no longer receiving their primary care. They didn't have primary care, meaning their care at home that keeps them out of an institution. So we had a lot of factors that impacted people with disabilities, those with cancer in terms of COVID-19. So when we look at that, we say, okay, that's the medical model. Kind of makes sense, right? Because COVID, we're talking about all the medical needs. Well, what we found and what we're listening to today is really what becomes more of the social model. And the social model takes that same example and says, yes, you're a patient, you have a disability, you might also have cancer. But the bottom line is we're not going to look at that in terms of the medical diagnosis. We're looking instead at what the interactions are with the environment. What have we set up? What types of barriers are there? And as you've already heard, COVID highlighted some of these barriers, the barriers to equity, the barriers to looking at an equitable response. These were items where we began to shift away from the diagnosis and to say, how can we look at this response operations and put that focus on equity in terms of what we're doing? I myself work for the Federal Emergency Management Agency. I do specialize in at-risk populations. So I had the pleasure of kind of working with a task force that focused on equity in the COVID-19 response, including here with the state of Rhode Island. Keep in mind, we have the federal government, of course, but it's the state's responsibility. The states are empowered to take what they have and to move forward and look at vaccinations and sites and how we do things. And in our role, we were able to help guide the states. Let's see where we have our fixed mobile sites. Let's see where we're going to have our testing sites. But what was interesting is in terms of data, as we talked about, not a lot of data going in. And the data that was collected was based on what's called the Social Vulnerability Index. And what states, including Rhode Island, which did a phenomenal job in terms of the COVID-19 response and recovery, is you looked at that SVI data. And that SVI data said, okay, in this community, we have many people who have self-identified based on certain demographics. So the state would go back and say, okay, well, because we have a community where there's a high level of a particular race, ethnicity, we're going to then look to put in a mobile vaccination site there. We're going to open up testing sites there. Okay, that's fine. But then as was just described, what data was collected after that? not a tremendous amount of data, and certainly not data that said, let's say, you have a disability. No, we looked at other data. So how we're going to move forward and get a sense of the next steps is going to be very interesting based on the conversations that we've had. From my perspective and our perspective at FEMA, we have launched multiple equity initiatives based on executive orders that have come out from the president that said, you need to focus on racial and ethnic and other underserved populations, especially during COVID. Many of you here today have participated in stakeholder calls and said, hey, listen, here's some barriers that we're having. So COVID-19 definitely highlighted the inequities that we've seen. Many of them have been historically here in healthcare for quite some time. But what it did come up was really looking at some of those key components, triage, as I said, rationing, and the questions that came out, how do we determine, and whose right is it to determine whose life we can move forward in terms of things? We had a lot of resources that weren't available, very stressed healthcare system. And so the impacts as we move forward are going to be very interesting, as was talked about in terms of our treatment and moving forward. So when it comes to this population, people with disabilities, those especially who have cancer, we have seen the impact over many years of different disasters. I mean, whether it was, hurricanes, floods, what's happening right now in Florida, the tremendous impacts. But COVID-19 definitely gave an equity lens in terms of looking at what's really happening with this population when it comes to equitable access to screening, equitable access to treatment. And so moving forward, what we'd like to do now is we're very interested in hearing your thoughts. What are your thoughts? What are some of the experiences that you had? And how can this panel of experts here share some insights to it? So while we open it up for questions, feel free to go to one of the mics for a question, or if you're online, I know someone's watching the Zoom online. And I'm going to start it out. I'm going to start it out with a question for you, Doctor. What strategies do you feel, based on what you talked about today, can be implemented to really improve those post-pandemic screening rates in the underserved populations? While other people are thinking about their questions, any thoughts on that?
Sure. And so the first thing is awareness. Making sure that we understand we have to reach out to those populations. And I think, again, doing this type of conferences and summits and trying to bring people together so we can create awareness, then they can go out to their communities and they can put plans in place to bring more people towards screening. I think that's the first step, and I think that's what is being done here. And a lot of the resources are being used for that. The second part is, having, as I mentioned before, navigation programs. Those take a little bit longer to create, but having a way to allow underserved populations to access the system and access their screening test in a cultural sensitive way. That's also very important. At the end of the day, a lot of it depends on funding. So you need funding for these programs. I think there are a lot of groups that have been actually working a lot on this. The American Cancer Society has been a leader, putting out grants for navigation and creating a platform to facilitate institutions to have different programs for underserved populations. And there are many other groups. The Department of Health actually has a navigation program, and they have funding from the CDC. So it takes a little bit of time, but I think if we can retake all those strategies that we were using before, we should be able to reach to these groups and bring them back to screening. Now, something that I think is very important is that now we have two problems: not only to reach the underserved populations, maybe we were not even reaching before COVID, or we were reaching not in the best way, but also we have to catch up with all the screening that wasn't done. And I do agree, we still don't know the impact of that year and a half without any screening is going to have on the long term. We're going to need to wait for that, but we can assume it's going to increase mobility and mortality from the stage migration that we're talking about.
But I think,
Great.
as important though is COVID-19 not only exposed, the issues with equity, it's made our job harder because of the extreme efforts that have been made to push misinformation. So I think that has been a spillover effect where things we've always assumed as a society helps everybody, childhood vaccination, is now being put into question because people have questions about mRNA vaccines. And I think that's the same thing that I'm concerned about, where if we go into these communities, not to assume everybody believes a mammogram will help you find breast cancer early. Because at this point, we are dealing with a lot of mistrust that I think has just mushroomed out of our control. And it's not for the sake of trying, but we are up against social media.
Mm-hmm.
And unfortunately, social media doesn't guarantee equal access to good content as well as the content you want to see. The algorithms are built so that you see the content you are interested in, good or bad. That's what you're going to see. And that reinforcement mechanism is a big problem that I think we are still dealing with.
Excellent, excellent points. Thank you for sharing. And I see that we have a question in the audience, sir.
Hi, my name is Peter Marcelia and I'm with Roger Williams. One of the points that you made on really discrimination almost and the unconscious bias that we continue to face with the LGBTQ community. And I was wondering if you could talk about maybe best practices that you've seen. I've actually had the opportunity to work in healthcare and financial services. So I've been to the training, I've been to the unconscious bias, I have the emblem, the badge, but you know, it seems to, in healthcare, it brings it to a completely different level. And I still struggle with how to get that message across.
Yeah, I think that's a great question. And again, everyone in this room should access an online program on implicit bias. It's offered at Harvard University. And it's revealing. And one example of how revealing that is that they did this in a medical student group-wide, just about lesbian, gay, bisexual people. And almost all of them had an implicit bias against LGBT people that they were not aware of. There was also a concerning small minority who were explicitly biased against them. But these are our blind spots. Unless we know about our blind spots, we're not going to be able to change them. In terms of best practices, I think not only having the organization support LGBTQ rights as part of its mission statement, its value, its core values, that is the bare minimum that I think we all should make sure your institutions have it. And if they don't have it, we need to push for it. But at the ground level, and I think this is the hardest thing to do, because as healthcare practitioners, we're not comfortable with confrontation. But when you see a bias play out, one of the things you can do is lead by example and call it out. And this does not mean being placed on the internet, being called a Karen or a Ken because you're making a ruckus. But what it does mean is, do you understand that how you just said that could be construed as unfriendly? And I do this now, all the time. I'm taking care of several trans people, and my staff will email me and they'll say, oh, she has a urinary tract infection and is requesting a med. I could let that go. It's just in an email. But I think it's a point of continuing medical education when I point out, let's prescribe this. By the way, they go by they, them pronouns. And I make that, it's just a very simple thing. I'm not calling anybody a name. I'm not saying that they're homophobic or trans denying. I'm just pointing out, this is a person in our practice. These are the pronouns they go by, not the pronouns they prefer. These are their pronouns.
Excellent. Thank you. Great question and great feedback. I see, Joe, you had a question?
Yeah, I was going to say that I spent my career pretty much in behavioral health. And one of the things that we ran into, as you all recall, was not in my backyard. You know, the stigma associated if you had been in a mental hospital or mental facility and sought those services. And it seemed that the only way we were able to sort of break down when we talk about education was that kind of relationship building, people being in the community, interacting with people in the stores, et cetera. There was sort of an acceptance, and that stigma that people had seemed to sort of disappear. I guess my question is, we talk about today, so much of it goes toward media, telemed visits instead of in-office visits and so on, which I think sometimes makes it harder to build those kinds of relationships where what you've talked about, strategies, are maybe a little more difficult to implement because there's a little bit more impersonal stuff. I mean, I get text messages, I'm sure, as we all do. Don't forget about your appointment, this or that. So I guess my question is, because I'm starting to ramble here, is how can we take the media in a positive direction to accomplish some of the strategies that you talked about? Because we know that media can take us in a negative direction.
Great question. Doctors?
Yes, I actually, before I get into the media question, I want to go back. I think that's unconscious bias is a very important topic, and I just want to go back to it. And you can see it from different perspectives. For example, there's a nice article from Baltimore, Johns Hopkins, where they analyze with underserved populations that have different language. They analyze the response of the staff members and the attendants taking care of those patients. And they made some surveys before and after. And the surveys before the attending or the staff had to meet that patient that her primary language wasn't English was every time they had a patient who didn't speak the language, they were thinking, okay, this is a patient who's going to take more of my time. This is a patient that I now need a translator. This is a patient that now I need to go and take a look at the machine to see if we can actually communicate. So they were looking at every patient that didn't speak English as a first language has a burden to what they were doing. And when they analyze a little bit further, it's not only the problem of the unconscious bias towards someone who doesn't speak your language, but it's also the fact that they needed to see this amount of patients in a specific amount of time. And if you know that your staff is going to be taking care of patients with specific needs, meaning language barriers, then the time to take care of that patient should be greater. So instead of 15 minutes, you need to have 25 minutes. So we need to start tailoring our care based on the characteristics of our patients. Mm-hmm. So you can imagine that you're going to talk with a physician about cancer, let's say, which is a very complex conversation, and the physician is already thinking, oh, God, here we go. Now I have to get a translator to try to explain to this patient who's already in a lower socioeconomic and educational level all the steps that we need to take through this. So again, I just wanted to highlight how important education of the staff. And then the other point is having a diverse staff. We need to have more diversity in the people who's actually taking care of the patient. We need to make sure the patient who's getting ready for the appointment feels more comfortable and with people that is more sensitive, not because they did a course, but because they share the same values or they share the same culture. So I think having a more diverse staff helps a lot into the unconscious bias.
Great, thank you.
The media question we're going to let to.
Yeah, back to you now. Thank you.
So Joe, I wasn't sure if you were talking media in general or telehealth visits, but in terms of the social media aspects, there's a group that is actually convened by the WHO, National Academy of Medicine, and American Medical Subspecialty Society, and they're looking at that issue of trying to do a verification process on good information and trying to get social media companies to commit to sharing good information more than relying on their algorithm. Because if someone is looking for COVID-19 information, and say is looking for COVID-19 information specifically as it relates to them as a gay person, that information may pull up porn, or it may pull up COVID-19 and handicapped people, because the algorithm may treat gay as a handicap. Okay, so there is no control of the algorithm. So what we are trying to do is, and Meg Rani, by the way, is chair of this, is a co-chair of this group. We're trying to promote some ground rules that will say this content is worthy of being shared by your platform. If someone is looking this up, this is the content you should be sharing, because it's not happening now. In terms of telehealth itself, though, you're right. It has been a barrier. I've written previously about, what an awful experience it has been, telling someone they were dying of cancer on a telehealth visit and referring them to hospice on a telehealth visit. And I've had conversations with colleagues across the country who say it does not need to be a horrible experience, that there are ways to connect on a video screen. And I think one of the things that was the example given on a video screen, you don't need to wear a mask. Okay. And that has changed, in many, many ways. It has really changed the patient-doctor dynamic in an exam room. But there are ways to utilize telehealth in a sensitive way and keep the emotionality of those visits intact on screen. That is a skill. It is not a skill that most of us are going to adapt. Because I remember pre-COVID, I was at Mass General doing sexual health visits by telehealth, and I was trained. White screen in the back, nothing on your desk, no tchotchkes, very professional, private. We did telehealth post-COVID-19. All of those rules went away. They were like, just do the visit. All of your patients, you're 30, they're going to be on telehealth. Just do the visit. And you would be sitting in a shared workroom. All physicians, no risk that PHI was going to leave that room. But they were privy to what I was saying, even though I was speaking in a mic. And that wasn't ideal. And they could be seen in the background, or my NP's in the background, or an MA is in the background. That's not ideal. I don't know if you had any more thoughts on that.
No, those are excellent points. And we still have a little more time for more questions. If anyone has any questions. In the meantime, I do have a question that came up. In consideration of what you've talked about right now, and you mentioned a little bit about cancer mortality, what do you feel is the impact the COVID-19 pandemic low screening rates will have on cancer mortality? Any thoughts on that in terms of the question that was submitted?
Yeah, well, I think we already kind of talk a little bit about that. I think the fair answer is we don't know. I think that would be the fair answer. If you ask me my opinion, I think, yes, there's going to be an increase depending which cancer are you talking about. Because, for example, if you talk about colorectal cancer, we know that it's not only about screening, but it's also about prevention. When someone has a colonoscopy, you can not only detect early cancer, but you can also detect polyps that were going to become cancer. We don't know which one are going to become or not, but you can affect the incidence of the cancer by removing polyps. There's some other screening where we just detect the disease. So it's very, it kind of depends on what type of disease are we talking about. In the case of colorectal cancer, again, we don't have data. We have to wait to collect more data after COVID. But I think there's going to be an increase in the stage at which patients present. And there, we do have data that a lot of the cases, cancer cases that were done across the country in an emergency setting during COVID were advanced cancer patients. Patients who came with GI obstructions, with biliary obstruction, patients who actually had more advanced disease. We know that because, you know, the only reason you're going to go to the ER during the COVID pandemic was if you were actually having a real problem that usually associates with more advanced cancer. So I will say, I don't know. We don't know yet. We will know in a couple of years. From my perspective, I think we're going to start seeing a little bit of more advanced cancer stage at diagnosis.
Yeah, and I think that one of the concerns that's been raised as well, when you look at the population of people with disabilities, in particular, if we're looking at, let's say, women with disabilities and breast cancer screening, there's a lot of concerns, a lot of barriers even before COVID, right? I mean, Rhode Island was one of the leads in terms of looking at the research several years ago in terms of access to screening for women with disabilities, and looking at, you know, mammograms. And at the time, you know, they were just not an accessible machine. We had women who, you know, could not have their mammogram because they couldn't stand. They could not hold their arms over their head. We had women whose arms were taped to the machine. It just resulted, this research resulted in lots of barriers. And luckily in Rhode Island, and several people in the room here today, you know, worked to kind of raise awareness to this. And now the screening equipment obviously is much better, as best as it possibly can be right now in terms of things. But you take that population that it took so long to say, okay, the barriers are better, we can get in, the rooms are accessible, things will work, you know, at least a little bit better. And years of working on trying to get that population in for screening. Now we're looking at COVID. And as you said, people are not necessarily going back for their screenings. Screenings have been missed. So we're looking at sort of a double jeopardy in terms of that. How do we now get the word back out after doing all this work for access to healthcare, especially for this population, and reminding them that, you know, it is worth going to at least get your screening. So definitely an area I think that we're going to have more research on. Again, if we have a few more minutes, if there's any more questions. If not, we did have one other question that came in, and I think, Doctor, this is more for you. In terms of the demographic collection in oncology, as it relates to some of the data, do you think that we're going to have a better understanding of how COVID has impacted SGM communities?
Mhm. Yeah, you know, I think that's, if you look at the data from the state of Rhode Island, it's actually quite interesting. Number one, I think the data which was collected in 2021, so this was after vaccines became available and we had medications to treat it, are the COVID cases that affected the LGBT community was exceptionally low. And it was less than 6% of people who identified as lesbian, gay, or bisexual got COVID in this state. And less than 1% of those folks were self-identifying as trans or non-binary. And if you look at hospitalizations, there was no difference. If you were LGBT or were not, it was the same, it was at about 4%. But the biggest group, Kelly mentioned this, the biggest group where the hospitalizations were the highest was the group who did not declare sexual orientation and gender identity. They were almost doubled. 7% of that group got hospitalized. 4% if you declared. So what does that tell you? It's like, I have no idea what that tells us, you know? It does tell me, if you're dealing with a 30% non-disclosure rate, let's say, it means that we as the state, we in this room need to make the case of why the data collection is important. It's already available in every EMR that is in all of our institutions. We have the ability to collect SOGI, sexual orientation, gender identity. There is no mechanism, there has been no implementation at the institution level or at the state level to make that happen. And if we're just going to sit in the room and say, yeah, we're going to make that happen, we are bound not to succeed. And that's the take-home point for you as far as the state's data collection efforts. It was voluntary, but perhaps we need to do the better job of explaining it. And maybe on a piece of paper saying, we now want to ask you about your sexual orientation is an insufficient way to explain to people why we're collecting that data. But it also tells me one other thing of concern. like I said earlier, my community, the LGBTQ community, has experienced bias, has experienced difficult situations in healthcare, and I am not an exception to that. My daughter sought care, and when my husband said, was asked, "Oh, what's your wife's name?" on the phone by the intake person, he said, "She has two fathers," gave my name. Pause. "You need to bring in your adoption record so we can verify parenthood." I know for a fact that is not something that is ever asked and has never been asked of me. So again, goes to explain that when you're thinking about the rollout of SOGI data collection, people in this room are not the only ones who need to be trained of the importance of it, the sensitivity of it, and I think more importantly, how to handle mistakes. So you will have a transgender patient, a trans man in your offices one day, and you might slip and say, when you were growing up, or you may use the pronoun she, "Oh, nurse, this is a person or a person with breast cancer. She needs a CT scan." Having the grace and the dignity to look at your trans patient and say, "I'm so sorry. I'm going to try harder." That does so much. But because of this experience, and I'm sorry, I went on a total tangent, but
Good information.
because of it, what I fear is that this community did not seek care, did not go to the emergency room, did not go to the hospital, did not get tested. So may be undercounted because of the lack of trust in the medical system.
Mhm.
And if you ask, well, what's their experience after COVID and cancer? And I would love to hear from other providers in the room. My concern, and I don't know why it would be, but I've had women with ovarian cancer who are lesbians come into clinic recently, and they're not responding to chemo. In fact, one of those women I sent to hospice after she progressed on frontline therapy, and it was the most devastating thing I've ever seen. I don't remember seeing that rash of people coming in with platinum resistant or platinum refractory to disease, and they all tended to be in same-sex relationships. That is an anecdote. This is the importance of data collection. We need to see if the anecdote generates a hypothesis, and that hypothesis needs to be evaluated on a population-wide basis, because otherwise I'm just going to scare all of you and say lesbians with ovarian cancer are not going to respond to chemotherapy, which is not the case.
Yeah, really good points. And I think the point that you brought up too about trust, when you think back to COVID, one of the most significant factors in actually assisting people or encouraging people to go and get their vaccine, to go and get tested, was that trust. I know in Rhode Island, you had actually a big tour around when the Civic Center, the Dunkin' Donuts Center was a huge vaccination center at the time. You had a huge tour of trusted leaders from lots of different communities in Rhode Island that came in, and they had a tour from the moment that an individual parked all the way through, so that they could go back as those trusted sources from their community, say, okay, I've been there. I've seen everything. I'm going to recommend, or not, whichever it might be, that you go for this. So that issue of trust is huge. So today we've heard a lot of good insight in terms of whether it be plans in place, resources, training, looking at who our staff are, how we interact with our patients, taking those lessons that we've learned from COVID and saying, okay, what can we do now? So in closing, I would just like to ask you if you had maybe just one recommended next step that we as a collective group here, from Rhode Island could do to start to move us forward. I know data is a huge issue, but one particular maybe component or recommendation that you'd have, we'd love to hear it.
You first.
Well, what I would recommend is, as we go back to our own healthcare systems, I think we should take a deeper look into what community are we caring for. what are the needs of that community in terms of the culture, the language, the sexual orientation, and then try to create a platform where you can provide care in a very sensitive way. Making sure that the patient understand you're there to help them, to navigate them, to have them get access, and to understand what the benefit of all that is. But I think we need to start kind of personalizing the way we offer our care.
Yeah, that's a great point. Individualized, we have it, we tend to generalize and, look at populations as a whole, but to really take that step back, get to know the individual, really understand who they are, where they're coming from, whatever it might be. I've seen over the years, several doctors, one in the room in particular, who got to know a patient's whole family, knew everybody. And that was so critical in terms of having established that trust in terms of things. So how about, Doctor, anything that you'd like to add?
Yeah, I think I would say if you haven't started the conversations on demographic data collection, start having it in your institutions. And when I say that, it's not just SOGI data, but think of diversity, equity, sort of in an intersectional way, because this society we live in can be, subdivided by race, certainly by age, you can do it by gender, but as important, and we mentioned this, physical status and limitations, urban versus rural environments, insurance or no insurance. These are all really important ways. To assume every person in this room has had the same life experience would be incorrect. But finding a way within our institutions of describing the experience that we have as people working in an institution, that's what intersectionality to me is. And that is also the very definition of diversity and inclusion. And I think this is where this all fits in. Okay, so if we acknowledge that we're all diverse people in our institutions, we then need to collect the same kind of data for the people we serve so that we can see where our blind spots are.
Excellent. Wouldn't it be wonderful if we came back in a year or two and said, okay, this is what the data showed, right? But in the meantime, I just wanted to thank both of you for your excellent insight. I think we were lucky today to have such wonderful subject matter experts here. Take the time out of your busy schedules to join us. And I'm going to turn it back over to Jim now. And thank you so much.